So welcome to our 7 habits of long-term care programming. Like we talked about last week, we're going to just divide this into nice quick little snippets so that you have a quick 10 to 15 minute habit that you can learn each week so that you can really focus on making that change in your documentation or just upgrading kind of how you're doing things just based on what we're covering that week. So this week, what we're going to talk about is just choosing your medical and treatment diagnoses. When we're choosing our medical diagnosis, there's two main questions that we need to be asking ourselves. First, is it relevant to the reason why the patient is being seen for therapy? So we don't want to just pick any random medical diagnosis that we see when we look into PCC, which we're going to do in a minute. We really want to take the time to think about what diagnosis is the reason that this patient has had a decline. What diagnosis is the reason that this patient needs my services? And then we also have to make sure that the diagnosis is still active in PCC. And again, we're going to look at PCC in a minute to see what that looks like. If we have a diagnosis that's in PCC, it's under their medical diagnosis, we're good to go and use it. If we have a diagnosis that's not in PCC yet, I'm not saying we can't use it, but there are some extra steps that we have to take. Oh, this is not the most updated slideshow. Okay, I'm going to just talk about the rest of it then. When we're choosing a medical diagnosis, what we're looking at is it's different for our Part A and our Part B patients. When we're talking about our Part A patients, our skilled, our short-term patients, you want to use one of your treatment diagnoses as your medical diagnosis. I know that sounds weird, but when we're talking about a Part A patient, we don't want to try to guess what the skilled diagnosis is that the team's going to use. So we use one of our treatment diagnoses just as a placeholder, just to make sure that we can save our eval, because NetHealth won't let us save it without a medical diagnosis, but we don't want to try to guess what that skilled diagnosis is. The reason for that is it has to match. It has to match what's on the MDS. It has to match what's in PCC. And if we try to choose that ourselves as soon as day 1 or 2 when we're in there doing that evaluation, we run a high risk of them not matching, and we have to go in and change our documentation. And if it's already been signed by a provider, it can just lead to a lot of other issues. So what we're really focusing on today is when we're choosing our medical diagnosis for our Part B patients. So for our long-term care patients, we do not want to just use a treatment diagnosis. We have to have a medical diagnosis that is there to support the therapy that is being provided. So when we're looking in PCC, if you go under the medical diagnosis tab in PCC, you're going to see something that looks similar to this. And it's going to list all the different medical conditions that that patient has in their medical record. So as long as these are in PCC, it means that it's an active diagnosis, and it means a physician has verified that the patient has this diagnosis. So we can choose whichever of these diagnoses are appropriate. We do not need to choose every one of these diagnoses. I've looked at different claims before, and sometimes people put every diagnosis on here. You know, you look at a speech claim and it's got, you know, muscle weakness, repeated falls, difficulty walking. Let's see if there's any other on here that isn't really hypothyroidism. You know, we don't need every single one of these codes. We just want the strongest 1 to 3 medical diagnoses that really support what it is that we're doing with those patients. So in this case, you know, you're really going to look at what the weaknesses are with that patient, and maybe it's due to their acute and chronic respiratory failure. Maybe it's due, if it's a behavior case for OT, maybe it's due to their anxiety. If it's speech, it might be due to this malnutrition. So we really want to make sure that we're looking through these diagnoses and not just randomly picking one, but picking the one that relates most to our treatment plan. Similarly, when we're talking about our treatment diagnoses, our treatment diagnosis is the treatment is for the condition for which therapy is being rendered. So we want to stop and think. I think we all get into these habits of, these are the 3 codes that I have for OT, so I'm going to always put M6281 R29.6, R27.9. But what we're finding is we're not supporting some of the treatment diagnoses in our documentation. It has to make sense with our evaluation, and it has to make sense with the goals that are written. So it should describe the problems that you identified on your eval, and it should support the goals that you've written for that patient. So for example, if we use the code for muscle weakness as our treatment diagnosis, that M6281, and then our evaluation says that the strength is within functional limits, then those two things don't add up. And when an auditor looks at that, they're going to say, well, we're using a treatment diagnosis that has absolutely no justification on our evaluation. Similarly, I've seen times where on PT, we use the treatment diagnosis for difficulty walking. I think it's that 26.2. But then we document that the patient isn't ambulatory, or we don't document anything about their walking or their gait. So we have to make sure that we're thinking about what treatment diagnosis we're picking that matches up with what our treatment plan is going to be. Does anyone have any questions? All right. Well, that is a really short one this week. If we don't have any questions, then that's all we really have for this week. So when you're doing your evaluations this week, really make sure to stop and look in PCC, see what our diagnoses are, and really make sure that the treatment diagnosis that we're picking as well makes sense. I did have a question come through that I wanted to clarify. Your treatment diagnoses do not have to currently be listed in PCC. You do not have to limit yourself to the PCC codes for your treatment diagnoses. The PCC codes are for our medical diagnoses. So if you're going to see treatment ones in there, because whenever we pick a patient up for Part B, those codes do get added into PCC. But if you do want to use, a dysphagia that might not be in there, or you want to use an R41.841 and it's not in there yet, that does not limit you. When I said we had to make sure it was in PCC or else talk to nursing about getting a query out to the doctor to have it added, that's only when we're talking about our medical diagnoses. Great question. Anything else? All right, well, we will get these slides sent out to all the DORs, the correct slides, because this one that I pulled up was not the final product. We will also make sure that you have the handout. If we go back to this slide where I showed you these two questions about the medical diagnosis, it's part of a handout that kind of gives you questions to ask for each section of an evaluation. And that's what we're going to be basing our weeks on. So we are going to make sure that you have that whole forum too. And next week, we'll be moving on to the next section and we'll be talking about reason for referral. So thanks for joining us today. And as always, just email us if you have any questions.
Thank you, ladies.
Thank you.